So the beginning of the hormonal control of the female reproductive cycle is shown here. We want to remember that all of the ovarian follicles are present at birth, but their development is going to arrest until puberty. At puberty, gonadotropin-releasing hormone is going to come out from the hypothalamus down the hypophyseal portal system and stimulate the anterior pituitary to release luteinizing hormone. Luteinizing hormone will travel through the bloodstream and down to the ovaries, where it's going to stimulate ovulation. Follicle-stimulating hormone is our other gonadotropic hormone, and we're going to talk more about that one in just a minute. FSH is going to stimulate follicular development, but it is LH that's going to lead to ovulation of the secondary oocyte, corona radiata, and zona pellucida from the ovary. Now also, we want to keep in mind that FSH is stimulating these granulosa cells to develop. As the granulosa cells continue to develop, they're going to release more and more estrogen. You can see how the ovarian cycle is regulated by FSH, and we're also now going to see a little bit of the characteristics of the uterine cycle on this slide as well. FSH is going to go out and stimulate the follicles. This is, in fact, where follicle-stimulating hormone gets its name. It's going to stimulate development of the primordial follicles into the primary follicles into the secondary follicles, and then the secondary follicles into the mature Graafian follicles. These are the ones that are getting ready to ovulate. And so LH is also going to be released, and that's going to lead to the ovulation. And so once ovulation takes place, the egg cell has been released, and we're then going to form the corpus luteum. This is also where the corpus luteum gets its name, thanks to luteinizing hormone that stimulates its development. The corpus luteum will be responsible for releasing 4 different hormones, namely progesterone, estrogen, relaxin, and inhibin. But estrogen and progesterone specifically are what are going to help regulate the uterine cycle. Thinking back, the uterine cycle is the development of the endometrium. It is estrogen that's actually going to begin the growth of the endometrium after the menstrual phase. But it is progesterone that, after ovulation takes place, is going to continue the growth of the endometrium. So we'll actually see that once ovulation has taken place, the corpus luteum is present to release progesterone and estrogen to continue the growth of the endometrium. Just remember where the estrogen is coming from initially, from those granulosa cells, and then the corpus luteum is going to take over estrogen release. Now, in the event that fertilization does not take place and there's no zygote that's formed, the corpus luteum is eventually going to break down because of lack of feedback and become what is known as the corpus albicans. This is going to degenerate away, and then the uterine cycle is going to start all over again with menstruation. Down here we can actually see the endometrium shown, and you can see with menstruation the thickness of the endometrium decreases, and at this pre-ovulatory phase that's going to start proliferating the endometrium thanks to the influence of estrogen. Here at ovulation we're going to release the egg cell, and then progesterone is going to continue the further growth of this tissue. The stratum functionalis is depicted in this lighter pink color, and the stratum basalis is shown down here. We can actually separate the uterine cycle up into several phases. We have the menstrual phase, the pre-ovulatory phase, ovulation, and the post-ovulatory phase. The menstrual phase lasts from about day 1 until about day 5. This is the actual process of menstruation that's taking place during this phase. But in the pre-ovulatory phase, these are all of the events that take place before ovulation, and the post-ovulatory phase is going to include all of the events that take place after ovulation. We can see these 4 phases listed right here. Now, it's also very important for us to remember that the length of the female reproductive cycle is different in all individuals. The normal range for this cycle is between 24 and 36 days, so we're going to consider it at 28 days on average. And it is thanks to the many different hormonal feedback loops that we will find here that will control and regulate this cycle. One of these feedback loops in particular that we're going to see is increased levels of estrogen during the pre-ovulatory phase. This phase is going to include the development of the ovarian follicle before ovulation. Increased levels of estrogen are actually going to increase LH and GnRH release, and we know that LH is the hormone that leads to ovulation. This graph will show you 4 different hormones, their concentrations, and about at what time in the female reproductive cycles that they are released. The first thing we want to notice here is the green dotted line, which is showing us estrogen. As the ovarian follicles develop, there's going to be more granulosa cells produced, and therefore more estrogen that's going to be released. That's going to lead to this increase in estrogen levels as we continue towards midway through the cycle. Increased estrogen levels are going to positively feedback to lead to more LH release. And you'll also find that we have more FSH release as well around this time. The LH spike is eventually going to lead to ovulation, and that happens right around day 14. So it would make sense that LH is increasing in its concentration right around this time. Now the other thing that we can see here is progesterone. Progesterone is coming from the corpus luteum, but we only get the corpus luteum after ovulation. So once LH has spiked, that's going to lead to ovulation, and then the corpus hemorrhagicum is going to become the corpus luteum. This is going to start releasing progesterone, and that's why we see an increase in progesterone levels. We also want to keep in mind that estrogen is also released from the corpus luteum, so we'll see those levels going up here as well. This slide will tie together some of the feedback loops that we will find and the hormones that are released to regulate this cycle. GnRH is going to lead to FSH and LH release. FSH is going to go and stimulate the ovarian follicles, and also their release of estrogen. Estrogen is going to be shown right here with all of its different roles. Estrogen, being the female sex hormone, is going to promote development of the female reproductive system and also development of the secondary sex characteristics. This will stimulate protein anabolism and also help to stimulate the growth of the endometrium. Inhibin will also be released by the granulosa cells, and inhibin is going to feed back on the anterior pituitary to prevent the further release of follicle-stimulating hormone. Now, LH, on the other hand, is going to lead to ovulation and also the development of the corpus luteum. The corpus luteum will release progesterone, estrogen, relaxin, and inhibin, and you can see all of these roles shown down here. We've already looked here at estrogen and inhibin. More secretion of those hormones from the corpus luteum will further increase these negative feedback loops. But it's progesterone and relaxin which are the two we haven't discussed quite yet. Progesterone is going to further stimulate the growth of the endometrium, and this will work with estrogen to do this. Relaxin, on the other hand, as it sounds, will relax the uterine smooth muscle and inhibit muscle contractions. We'll also find that relaxin is going to increase pubic symphysis flexibility and also the flexibility of the other joints that are around that area. In high concentrations, relaxin will help to dilate the cervix, which opens up the uterus for labor. So many of these different hormones are negatively feeding back on the further release of GnRH as well as FSH and LH. I've also told you now that high estrogen levels are going to stimulate further release of LH as well. So it just depends on what part of the uterine cycle that we are in. So this slide will just serve to summarize these concepts and all of the hormonal feedback loops that we see here regulating the female reproductive cycle. The first thing that's going to happen is at puberty, GnRH is going to be released from the hypothalamus, stimulating FSH and LH release from the anterior pituitary. FSH is going to further the development of the ovarian follicles, which will eventually lead to the secretion of estrogen. Estrogen is going to stimulate the growth of the endometrium after the menstrual phase, and also the release of inhibin, which is going to feed back and prevent further release of FSH. LH, on the other hand, is going to stimulate ovulation, and it will also stimulate the formation of the corpus luteum. The corpus luteum is going to release estrogen, progesterone, relaxin, and inhibin, and we see inhibin's feedback loop shown here as well. Progesterone and estrogen are going to further the growth of the endometrium after ovulation takes place. In the event that no fertilization takes place, the corpus luteum becomes the corpus albicans, and that's no longer going to lead to estrogen and progesterone release. This is going to lead to low levels of estrogen and progesterone, which is going to increase GnRH, FSH, and LH release through negative feedback. If these hormones are in low concentrations, GnRH, FSH, and LH have nothing to be inhibited by. Now, in the event that estrogen is in very high concentration, that's going to positively feedback on GnRH, FSH, and LH as well. And with increased LH, that's going to lead to ovulation again in the next cycle. Now, the last major concept that we're going to cover in regards to the reproductive systems are a few birth control methods that can be used to prevent conception. We're going to talk about a few different methods, including surgical sterilization, different hormonal methods, as well as abstinence. It's important to note that abstinence is the only 100% reliable method out of all of these, but we will come to find that there's quite a bit of efficacy to many of these other methods. The first group that we're going to discuss is sterilization. There's surgical sterilization and also non-incisional sterilization as well, which will be a little less invasive than these other two. The first of which is the vasectomy. The vasectomy is a surgical sterilization procedure used in males that focuses on cutting the vas deferens and preventing sperm cells from leaving out of the penis. Without that connection point, it is much more challenging for sperm cells to leave the male body. A rather interesting fact about vasectomies is that this is actually a reversible procedure. Tubal ligation is similar, however this is used to cut the fallopian tubes in females. By preventing egg cells from making their way into the uterus, conception significantly decreases in its likelihood. The non-incisional method refers to taking this coil that's made of plastic and metal and placing it up in each uterine tube. Based on this, that stimulates the growth of scar tissue, and that prevents the oocytes from making their way down the tubes and into the uterus. The hormonal birth control methods are generally administered in pill form. These methods typically target one of the hormones in the female reproductive cycle to make the environment much less hospitable for conception. Combined oral contraceptives include both progestin as well as estrogens. Progestin is a chemical that's very similar to progesterone, and this chemical is going to lead to the thickening of the cervical mucus. In the event that the cervical mucus is thick enough, that can prevent sperm cells from making their way up into the uterus. Many pills contain progestin as well, and there are really many different ways that these hormonal methods can be administered. These can be utilized in the skin patch, in the vaginal contraceptive ring, or also in the IUD. There are also emergency contraceptive pills that are once again designed to make the uterus much less hospitable for implantation. On top of these hormonal methods of birth control, we'll often find spermicide being used as well. Spermicide inhibits the action of sperm cells, and by inhibiting their transport up to the fallopian tubes, that's going to make pregnancy much less likely. Spermicide is also often used with the barrier methods, which include the male and female condoms, as well as the diaphragm and the cervical cap. These are two very similar methods that put a block around the cervix and prevent sperm cells from entering up into the uterus. Again, this isn't 100% effective, so spermicide is often used with these barrier methods as well. The last method that I'm going to talk a little bit more about is abstinence. This is carried out by refraining from sexual intercourse at certain times during the female reproductive cycle. The first method you'll see here is the rhythm method, which is when ovulation is going to mark the times of abstinence. Checking other markers such as the cervical mucus as well as temperature are going to be guidelines for the symptothermal method. I just wanted to real quickly mention those birth control methods, and you'll see here on these next couple slides a few statistics about each of their efficacy. As this chapter comes to a close, I do just want to mention that puberty does start right around age 10. Give or take a year or two, this is going to be the time when gonadotropin-releasing hormone is released from the hypothalamus and starts the process of spermatogenesis in males and oogenesis in females. A few homeostatic imbalances that relate to the reproductive systems is testicular cancer in males, prostate cancer and other prostate disorders as well, and also erectile dysfunction. Women are especially susceptible to breast cancer and ovarian cancer, and endometriosis is when tissue that's very similar to the endometrium grows outside of the uterus. This slide lists just a few sexually transmitted diseases, including chlamydia, trichomoniasis, gonorrhea, syphilis, genital herpes, and genital warts. You'll find these further described in your textbook, so make sure to quickly go look over those pages. So as we typically end each chapter, I'm going to just real quickly mention how fertility and vibrance of the reproductive systems tend to decrease with age. We have to keep in mind that women do have a limited number of oocytes. So by around age 40, the ovarian follicles are not going to be as healthy as they once were. Estrogen levels are going to decline, and that's going to indicate that the endometrium will not be as thick as it would be in a younger woman. In men, we will find that reproduction is still in fact possible into very older ages. In the 80s and 90s, males are still able to reproduce. However, fertility is going to decrease because sperm cell levels are going to decrease and libido is going to go down. Along with this, the prostate does tend to enlarge with age as well. So the big picture here about the reproductive systems is that these are going to be the avenues for producing new individuals and perpetuating the human race. Make sure that you have a very good understanding of male reproductive anatomy and physiology as well as female anatomy and physiology. We're going to move forward to our final chapter, which is chapter 29, that will cover the events that take place after fertilization. Chapter 29 will cover pregnancy, development, and inheritance. If you have any questions about this chapter, please let me know, and I will see you all in our next lecture video, where we will begin covering our final chapter in Anatomy and Physiology 2.